All right, we are. Good afternoon and welcome to Child Care Aware of America's COVID-19 and Child Care, What's the Latest webinar. We're so glad to have you joining us. This webinar is being recorded and it also is being live streamed on our YouTube page. So if for any reason you are not able to stay in the session or get back in, you can join us over at YouTube and watch us there. I am excited to introduce to you today Child Care Aware of America's CEO, Dr. Lynette Fraga. I'm turning it over to you.
Wonderful. Thank you so much, Kiami. Welcome, everyone, and thank you again so much for joining us for this very important webinar. Again, my name is Lynette Fraga, and I am the CEO of Child Care Aware of America. I'd like to start by thanking our co-sponsors, the National Association for the Education of Young Children, the National Association for Family Child Care, and the National Head Start Association for helping us to provide this webinar to the field and to all of you participating today. We are so very grateful that you have joined us for the latest updates on COVID-19 and childcare. We know that childcare professionals continue to address the pandemic with expertise and unending flexibility as situations continue to evolve. Today, we will hear from experts in childcare and pediatrics to learn more about how the pandemic continues to impact children, families, and childcare professionals. First, we will hear from Admiral Rachel Levine, Assistant Secretary for Health, who will provide us with updates on the administration's strategy for preventing COVID-19, including the importance of vaccines and boosters to reduce the risk of severe illness. After we hear from Admiral Levine, we will provide additional updates on CDC guidance for childcare, as well as efforts to prepare for vaccines for young children under the age of 5. Then we will hear from Dr. Tom Murray and Miss Keisha Nzui about their experiences in pediatrics and childcare. Last, we will spend the remainder of our time for questions. I'd also like to note that we will be putting together a follow-up document that includes questions asked today, including any that we may not have time to respond to during today's call. Now, to get us started, I would like to introduce Admiral Rachel Levine. Admiral Levine serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services and the head of the U.S. Public Health Service Commission Corps. She fights every day to improve the health and well-being of all Americans. She's working to help our nation overcome the COVID-19 pandemic and build a stronger foundation for a healthier future, one in which every American can attain their full health potential. Admiral Levine's storied career, first as a physician in academic medicine focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then, as Pennsylvania's Physician General, and later as Pennsylvania's Secretary of Health, she addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. And now I will turn it over to Admiral Levine. Thank you for joining us today.
Well, thank you so much, Dr. Fraga. I'm really pleased to be here and to speak with you all. So COVID-19 has truly been the biggest public health crisis that our nation and the world has seen in more than 100 years. It has impacted all of us in so many ways. In the United States, it has impacted our health, our families, our schools, our businesses, our healthcare system, our child care system, as well as local, state, and federal governments. First of all, as a pediatrician, I would like to thank you, all of the child care providers, and by extension, your families, for the extraordinary work that you have been doing over the last 2 years of the pandemic. Thank you. You have my personal and professional gratitude, as well as the gratitude of the entire United States Department of Health and Human Services. Your work has been so challenging, and I am so very impressed that even with the enormity of the COVID-19 pandemic, that you continue to provide excellent child care services to the children in our communities. Now, I want to take this opportunity to talk about what we know based upon the latest science on COVID-19. Certainly, the best thing that a person can do to protect themselves, to protect their families, to protect their community and our nation from COVID-19 is to get vaccinated and to get boosted. Vaccinations are so important. They are safe and they are effective. And the booster shots increase protection against hospitalization significantly, according to multiple studies. I want to highlight that the COVID-19 vaccination is recommended for people who are pregnant, breastfeeding, trying to get pregnant now, or might become pregnant in the future. And I also want to emphasize that there is currently no evidence that any vaccines, including COVID-19 vaccines, cause fertility problems. The growing body of evidence about the safety and the effectiveness of the COVID-19 vaccinations during pregnancy suggests that the benefits of receiving the COVID-19 vaccine outweighs any known or potential risks of vaccination during pregnancy. Now, let's focus a minute on boosters. Everyone 12 years and older can get a free COVID-19 booster. Now, who is eligible for a booster? So you're eligible for a booster shot 5 months after your second dose of the Pfizer, BioNTech, or the Moderna vaccine. So 5 months after your second dose of the Pfizer or Moderna vaccine, you're eligible for a booster, or 2 months after a single dose of the Johnson & Johnson vaccine. That's actually the one that I received, and I did get a booster 2 months after the Johnson & Johnson vaccine. So the best way that you can protect yourself and your family and your community against COVID-19 is to get a booster as soon as you are eligible. It's the best way to stay safe if you travel, if you gather indoors, if you're spending time with family and friends, or especially in the childcare setting for you all at work. It is especially important for people aged 50 and older, such as myself, or residents of long-term care settings, people with underlying medical conditions, people who are pregnant, recently pregnant, to get a booster because they are at increased risks for severe illness from COVID-19. Now, COVID-19 is also a very important step that we can take to protect children under 5. Now, we are still waiting for the data and the formal applications for consideration by the FDA for the vaccinations for children under 5 years of age. So the best way to protect these children, which are, of course, many of your clients, is to surround themselves with supportive adults who are boosted. their parents, their grandparents, maybe their older siblings, and yourself, their child care providers. So please, if you have not already done so, get vaccinated. And if you have not already done so, get boosted as soon as possible. You can find locations near you at vaccines.gov. And we have tens of thousands of vaccination sites. If you're already boosted, thank you. Please encourage all of your early childhood education colleagues and staff to get boosted too. Now, again, I'm a pediatrician. I'm a parent. Of course, my children are grown now. But I understand how scary it is to think of our children, particularly those under 5, who cannot yet get vaccinated. We have to do everything we can to protect these children. And I know that as child care providers, you have always gone above and beyond for children. You put them first. And so we're asking you to pull together to take this step for the young children. Again, it's important to surround children, to cocoon them with other vaccinated people, adults, family members, older siblings, and their child care providers to protect them and keep them safe. And that's why everyone should get vaccinated and boosted as soon as they're eligible. Now, at the beginning of the COVID-19 pandemic, say in 2020, it seemed like children might be less likely to get infected or have severe illness. But as the outbreak progressed and we saw the surge of more contagious variants, the Delta variant and the Omicron variant, of course, they're named with Greek letters, larger numbers of children and adolescents got infected and required treatment at children's hospitals. COVID-19 can cause severe illness in children. Children with underlying medical conditions are at increased risk for severe illness, although actually any child, even those without underlying medical conditions, could also experience severe illness. Current evidence suggests that children with special healthcare needs, which might be many of the children you care for, including genetic, neurologic, or metabolic conditions, or with congenital heart disease, can actually be at increased risk for severe illness for COVID-19. And we have seen many children who have required care in our expert children's hospitals, some even in the intensive care units, some who've required mechanical ventilation, and tragically, some who've died. Now, despite the heavy toll it has exacted, COVID reminds us of a fundamental truth, that we truly need each other, that our happiness and our very survival depends upon our connections to one another and to our community. And that spirit of community is what makes our country great. And it's what we need now more than ever as we seek to work through the COVID-19 pandemic. The pandemic has hit us hard, but we now know what works to keep ourselves safe, our children safe, our loved ones safe, our communities and our nation safe. Vaccinations and boosters are the leading public health prevention strategy that we have to end the COVID-19 pandemic. Promoting vaccination can help early childhood programs safely remain in person, which is what we want. Again, children who are not eligible for vaccinations, we need to surround them with vaccinated people. So let me quickly share where we are with the vaccines for children under 5. It is absolutely one of our top priorities to get a vaccine for young children that is safe and effective. The FDA, the Federal Drug Administration, is committed to acting urgently to save lives amidst the pandemic. And they continue to work with the pharmaceutical companies, with Pfizer and eventually Moderna, to review additional data on its vaccine for children under 5. FDA is in the middle of a thorough, independent regulatory process to review these vaccines. And if a vaccine is authorized, I can tell you it will have met FDA's rigorous standards, which is what we want. We know that early care and education programs can be safe if they follow the public health guidelines among mitigation strategies. We have other proven tools that the CDC has recommended at times, so that might have included masking, but also venting rooms, hand washing, covering coughs, staying home when sick, as well as cleaning and disinfecting. Of course, students, teachers, staff, children to stay home when they have any signs of any infectious illness. and if necessary, be referred to their healthcare provider for testing and care. So it's time to focus on what we can do rather on what we cannot do. One thing we can do is get vaccinated and boosted. We all play a key role in helping our children through this challenging time as parents, caregivers, educators, pediatricians, and other clinicians. The pandemic has shown us that we are all interconnected. The decisions that we individually make impact our families, our communities, our nation, and the world. And nothing is more important than the health of our loved ones, our families, and our communities. We can keep protecting them through vaccinations and boosters. So please stay connected, stay informed, and stay safe. Thank you.
Thank you so much, Admiral Levine. That was great. Hi, everyone. My name is Nikki Garrow. I'm Director of Early Childhood Health Programs at Child Care Resource America. I'm just going to take a few minutes to go over the most recent changes to the CDC guidance. And please be on the lookout for additional materials in the coming months as we try to help clarify some of the information that may be confusing. But I just wanted to quickly go over the latest updates, and then we'll get to our panel and the question and answer section, which is why we really are all here, right? So first, just briefly, there have been two recent updates to guidance related to early care and education. First, in January, there were two major changes to the guidance, one being to reiterate Admiral Levine's point to make sure everyone is up to date on the vaccines that they're eligible for. So for people 12 and older, that means that they're both fully vaccinated and boosted. For children 5 to 11, that means that they receive 2 doses of vaccine. In addition, there were changes to the isolation and quarantine guidance. If you'll remember before, it was 10 days after you either had a positive COVID test or were exposed to somebody who had COVID. This changed to 5 days, assuming that you can wear a tightly fitting mask for the remaining 5 days of that period. So as we all know, for children under 2, they would still have to adhere to the 10-day timeline. The CDC recently developed these great flowcharts to help make decisions about who needs to stay home and for how long. And we'll be sure to highlight those on our website as well. Then this month, there were some additional changes for where the CDC rolled out their CDC community levels related to COVID-19. As of right now, the ECE guidance does not include this information, but there is a note on the website that they are in the process of updating them. So please expect that the guidance will likely be updated soon. So this really strives to help people make decisions based on both the local area they live in as well as their individual needs. So the community levels are classified as low, medium, or high, and it's based on hospital admissions hospital admissions due to COVID, the percent of beds in our local area that are occupied by COVID patients, and new cases. So for everyone, regardless of the level, the guidance is to be vaccinated. Next, and for everyone, it's important that we pay attention to ventilation and disinfection, regardless of the area that you're living in. But for some people, if they're healthy, they might, and there's low rates of they're in the low category, the CDC now recommends now allows that you, or now does not not necessarily that you have to wear a mask. That being said, that could change at any time if the risks were to increase. Now, we also know that there might be some questions given, as Admiral Levine just discussed, you're all working with the largest proportion of unvaccinated people are children in childcare, right? Because those are children who are not eligible. So you'll be making some individual decisions coming up, and we really want to give you an opportunity to ask questions in a little bit so that we can, all of us along with our partners, can help inform you and help you support you as you work towards taking care of the children and yourself. So with that, I am going to start our panel now. First, I'm going to introduce our panel. We are so happy today to be joined by Ms. Keisha Nzui. She's Director of Public Policy at the California Resource and Referral Network. She has many years of experience as a community organizer and policy advocate in the Bay Area, California. Her background is in food policy, advocacy, and health, and this helps the network's advocacy and membership work. Her past work offered her many opportunities to work with federal, state, and local level elected officials. We're also joined by Dr. Thomas Murray, who is his associate professor at the Yale University School of Medicine in the Department of Pediatrics section on infectious disease, and the associate medical director for the infection prevention at Yale New Haven Children's Hospital. So with that, I'm going to turn it over to Ms. Nzui and Dr. Murray, who can give us kind of a flavor for what's happening in their experience as we're on the downward trend of the, or at least first Omicron wave. We'll see what happens next, as well as their experience working both in childcare and pediatrics. With that, I'll turn it over to Keisha.
Hi, thank you, Nicole. My name is Keisha Nzui, and I just want to preface my words by saying I am not a child care provider. I've never been, well, I forget that I was part of the child care workforce when I was in college for 2 years, but since then, that's not been part of my professional career until these most recent 6 years or so as an advocate. I just happen to be, I think, really lucky and privileged to be surrounded by people who have committed themselves to this career and this passion. So more than, as I look at the calendar, it's been almost exactly 2 years ago when California shut down and the rest of the nation followed suit going into quarantine. But childcare was truly the canary in the coal mine. Weeks before that full shutdown became reality, childcare providers were struggling to find cleaning supplies and food they needed to continue caring for the children. Almost overnight, many childcare centers found themselves forced to close because of new cohort guidance that prevented them from caring for enough children to be able to pay staff, to pay the rent, pay mortgages. Home-based providers were at Costco with the rest of us, trying to get paper towels or toilet paper or cleaning spray, yet you all persisted. Prior to the pandemic, childcare was already a scarce commodity. Parents struggled especially to find childcare for their infants and toddlers or care during non-traditional hours. Parents who were lucky enough to receive help paying for childcare got relief from some of the archaic racist policies put in place to put them in their place. Providers were temporarily relieved of their policing duties. But in this time of utter despair, we found what could be a childcare and early education system that serves and meets the diverse needs of all children, families, and ECE professionals, especially Black, Latinx, and Indigenous people and others harmed by systemic racism and additional injustices. The pandemic has brought out into the open the weaknesses of our childcare system and the resiliency of its workforce. Despite the immorally low wages paid to childcare workers, especially those who care for our youngest children, when essential workers needed care, our early childhood professionals were there, taking on the risk of illness, often without health insurance, and despite fragile health of their family members. Childcare providers, families, children, we've all experienced a mass trauma. Children losing their parents, their grandparents, providers becoming ill or themselves losing their lives. We've all really been through it over these 2 years. When I have the privilege to speak with and learn from childcare providers, I'm inspired because despite of all this, there is nothing else they would rather be doing than caring for and loving on our youngest children. This is evident in the lengths they took to stay afloat, taking out loans, maxing out credit cards, moving their programs outdoors because that would be safer, providing virtual activities when most folks were safe at home. And it's really evident in the way that we as parents not only depended on them, but trusted them. But parents who have kept their children home, either in those first few months of the pandemic or the first year, or even until today, may find that the care they knew and loved is gone. And a new one that is good fit will be harder to find than ever before. According to UC Berkeley Center on the Study of Childcare Employment, the childcare workforce has shown up 20% over the course of the pandemic. Again, in speaking with childcare programs in all settings, it's clear they're not immune to the Great Resignation. Whether it's Head Start or preschools or home-based programs, they're all struggling to find people like them who are willing to do amazing work for little pay, few benefits, if any, that the rest of us take for granted from our employers. And there's little incentive for younger people to enter the childcare workforce when pay is better in other jobs that require less training, heart, and passion. And 2 years in, we still haven't figured out a way out for our childcare system. But what I am warmed and heartened by is the dedication that our entire childcare workforce and system has taken to remaining safe, to keeping themselves safe, keeping children safe, and keeping their families safe. Thank you.
And now I'll turn it over to Dr. Murray, who can share his experiences working in a children's hospital.
Hi, everyone. Thank you. I have to apologize in advance. The Yale email or the Yale internet seems to be a bit clunky today, so I hope that it holds up. The first thing I want to do is echo previous comments to thank you for everything that you've done for the care of children during what has been a truly historic pandemic. And in my role in infection prevention, I've worked with a lot of community organizations and schools around trying to keep children safe when they congregate and come together. And the efforts that people like you have gone through are truly remarkable. And the resilience that's been displayed are heroic. And I don't use that word lightly. I also want to thank those of you who get surveys from us. I'm a member of Yale Cares, which is the Children and Adult Research and Early Education Study Team. And we've gotten responses from hundreds of thousands of early childcare workers, and we use that information to inform policymakers about what your needs are. So we continue to use the data to advocate for the kinds of changes that are necessary to improve the early child care system. So thank you very much for that. I'm going to talk a little bit about kind of areas to watch going forward based on some of the questions in the chat. In the Children's Hospital, we did see a significant surge of hospitalized children due to the Omicron variant. The good news is that we discharged every child that was admitted, which is great. So we did not have any mortality. A substantial portion of those admitted children were under the age of 5 because Omicron does tend to cause more upper respiratory symptoms and that seal-like croupy cough that those of us who are parents have seen our kids have when you run them out into the cold air so they can breathe a little bit better. So that required more hospitalization for the younger children, but we saw less of the lower respiratory disease and fewer children required intensive care, but some certainly did, echoing Admiral Levine's comments about while COVID is generally mild in children, it is not mild in all children. So with that in mind, how do we think about this going forward with a lot of options, especially with regard to the mask mandate? The first thing I'm going to say that I think is critically important is self-care. And that our data that you've sent us shows that many early childcare workers are struggling with anxiety and depression, as many of us are as a result of this pandemic. And as rates dip, even if it's temporary, it's really important to get out and take advantage of that. And if there are things you can safely engage in that give you pleasure and make you feel good, now is the time to do it while rates are low. So, if we need our workforce and people to really engage in self-care to take care of themselves. In terms of thinking about kind of how I approach infection prevention in a childcare setting, I put it in 2 different buckets. One is keeping COVID-19 out of the childcare center. So that, and the way you do that, which was previously mentioned, vaccination, vaccination, and vaccination. understanding that many of your clients are not eligible for vaccination. So then you start to really focus on things like symptom screening. So making sure children who come into the childcare are asymptomatic, and then testing. And that can be the rapid antigen testing for anybody who's symptomatic so that you can recognize cases early and try to prevent them from coming into the center. And as masks come off, what we've seen in our hospital is that the other respiratory viruses are coming back again, not just COVID, but influenza has a bit of an uptick here in the Northeast. And we even see a little bit of rhinovirus, which causes the common cold, and RSV, which is a very common reason for hospitalization in infants, another respiratory virus. So as COVID goes away, those viruses tend to come back because the masks are coming off. So it's important to distinguish which kid with the cold has COVID and which has other viruses. So then you think about things inside that prevent spread within the center, and masks are the key to that, right? And there's excellent data that have been produced by a number of different groups that show that masking of children 2 and older and of staff can help prevent spread of COVID. Now, that's not something that's I frankly never thought putting a mask on could be such a hot button topic, but it is. And people feel very passionate about it in both directions. And in many places, schools and childcare centers are lifting the mask mandate. So then what do you do in that situation? Well, then you try to focus on other risk mitigation strategies. And the ventilation piece of this is critically important. And so as the weather warms up in the north, and if you're in the south where the weather is already reasonable, getting outside as much as possible, opening windows and doors to allow good circulation of air, those are some really effective, cost-effective risk mitigation strategies. And then for the early childhood, distancing is very challenging. It's very hard to keep 2 2-year-olds far apart in a group. It's just not feasible in many cases, and I get that. But you can cohort groups so that if you do have a case, you prevent it from spreading to other groups. And I realize there's challenges with that in terms of staffing ratios, but certainly thinking about, if person A, if child A in this group gets it, can we keep this group of kids away so they will not be exposed? So it's really thinking about, what can you do to keep COVID from coming into your center? Vaccination being a key, symptom screening, testing strategies, and then what you can do to keep it from spreading within the center, where masking, ventilation, cohorting, and things like that come into play. And again, I'm happy to talk more about any of these issues and any other questions. But again, thank you for everything that you're doing.
Thank you, Dr. Murray. So now I'm going to invite, I believe Dr. Jonathan Warsh is with us as well. Admiral Levine had to leave, but Dr. Warsh is a senior policy advisor for COVID-19 with the Department of Health and Human Services. So he's with us as well. And we're going to start our question and answer session. And as Dr. Fraga mentioned at the beginning of the call, we'll try to get to as many questions as possible, but if we aren't able, we will provide a frequently asked questions document that we will send out to all the registrants after the webinar. So I think we'll start with, there are quite a few questions related to masking, as Dr. Murray addressed some of them already, but if anyone on the call could clarify, to your knowledge, what we know about masking and ECE as of right now. We know that the CDC has changed the guidance for the general population, and they are working on updating the ECE guidance as well. But if anyone on the call has advice for providers that are trying to make decisions for their the children they care for, or to protect themselves, if anyone had any thoughts, further thoughts they could share with them.
I'm happy to defer to medical colleagues on the call. From where we sit in HHS, we obviously defer to the guidance of the CDC and don't get ahead of the guidance of the CDC. But as you alluded to, Nicole, they are working on updated guidance. And so I realize it's sort of an evergreen statement. We're always working on updated guidance, and there's always something new that's coming out. Hopefully that will not be a recurring event, but I would sort of defer to the existing CDC guidance. And I would think that one of some of our medical colleagues on the call might be able to get a little bit more into where we are on the knowledge of the science.
Sure. I didn't speak because I want to give other people a chance to speak first. So the science, we published a study recently, and others have published studies in other settings, that masking is absolutely an effective way to prevent transmission of COVID-19. With Omicron being particularly contagious, a well-worn mask can be very helpful, but if it's very contagious in times when you don't wear masks, then the probability that spread is going to happen goes up. So I think that's important to think about. In terms of thinking about considerations within a center as to whether or not to continue masking, which is the current CDC policy, I just double checked. So the current policy, which has not yet been revised, is to continue to recommend masking. I want to be clear about that. But what schools, for schools though, that it has changed a little bit, and that may be coming down the pike for your centers as well in your programs. Things that I think about: what are the community transmission levels in your area? Epidemiology is local. So what, even like in a smaller state like Connecticut, what's happening in county A or city A may be very different than city B or county B. So that's important to have a sense of what is happening. And there are lots of websites that you can go to that have that information. Usually the State Department of Public Health will update it. So you want levels within your community to be very low. Having a sense of the vaccinated percentage of your workforce and also in the local area can also be important. Vaccination is certainly not perfect, but it does a pretty good job of preventing severe disease and death, which is ultimately what we're trying to prevent. I think if you have lots of special needs or immunosuppressed individuals in your population that are high risk, that is something else to think about in the risk benefit of the decision-making process. And that if you're going to continue to wear masks, the most important thing from my perspective in terms of what masks can accomplish, it's whether or not you can find masks that the kids are able to tolerate. And so, yes, in a perfect world, it's the KN95. They do have the younger child size, but what you really want is something the kid can keep on their face. Because if you're pulling it down all the time, then you're doing two things. One, you're exposing, your mouth and your nose to the aerosols, but you're also touching your face, which is touching surfaces and spreading infection via that way. And I think that the challenge has been, and the CDC has provided some new guidance around this, is around, having your push points or your trigger points to make changes. And I would love to tell you that whatever decision you make today is going to be the same decision for 3 months, but certainly you may have heard that there is the BA2 variant, which people are closely monitoring. And so it really does become critical to think about what is happening locally in terms of transmission rates. I also realized I did not give us like a yes, do this or do that, because it really is about risk benefit, and every program has to assess their risk benefit. I wish I could tell you, yes, do it at this point, but it's really hard.
There's another question about the vaccine and the vaccines and how they work in terms of first antibody production, but then kind of the longer term, I believe it's T cell memory, but the longer memory and kind of what that means in terms of how they work. I'm gonna go ahead and ask Dr. Murray to answer that one.
Well, I don't know, Nick, you were talking about T cells, so you clearly know something about.
Yeah, I know something,
vaccines,
but not enough.
Yeah, so that is correct. The vaccine, an antigen or a small piece of the virus, so it is not a live virus that is produced. It is nothing that gets incorporated into our host DNA. That's been a myth that's been out there for a long time. So it's just a small piece of one part of the virus that your body sees and your immune system makes the antibody to that. And it makes an immediate antibody response, which is very robust, which is why many of us who have gotten the vaccine will have things like fever and just not feel great for that first couple of days. That's your immune system producing that, which is good. It's producing that good antibody response. And then over time, levels go down, which is the reason that we have boosters. But there are these memory T cells that Nikki was talking about that kind of retain having seen that piece of the virus, so that when re-exposed, the numbers of those cells in your body will expand such that you can make more antibody in that way as well. So it's both B cells and T cells that help the body respond to the infection.
There's a question specifically about infants and what to do for quarantine and isolation when their sibling may contract COVID. Are they supposed to stay, and are parents supposed to stay home even if they're fully vaccinated?
You want me to take that one?
Sure.
Jonathan, you're welcome to jump in, or Keisha, anybody who wants to jump in.
Yeah, go ahead, Dr. Murray.
Feel free. So the CDC has updated its quarantine guidelines, and I got to be careful because I don't have all the different guidelines memorized because they've changed so much. Certainly, vaccinated individuals no longer require quarantine, for sure. And to me, regardless of the guideline, it really depends on the nature of the exposure. So what I mean by that, even if quarantine is not strictly required, if you have two infant siblings who are both unvaccinated and one has COVID and they spend, half the day together in the same room playing in close contact, it's highly probable that that sibling is going to have COVID at some point. So I think in that case, quarantine is a very reasonable thing to do. But in general, vaccinated individuals do not need to quarantine. Ideally, even unvaccinated individuals, if they're not quarantined, need to wear a mask, and they do need to get tested. And there's lots of rapid tests are now available. They're available from the government. I think they now increase the number of tests you could get. It was originally 4 per household. But Jonathan, you can correct me on this. I think you can get 4 more per household.
Yeah, it's now 4 more per household. So you can go to covidtest.gov. The other thing I will say, and we really need help getting this message out, is that there are lots of different ways that people can get access to these tests. And we encourage people to order them now rather than waiting until they're in a pinch. So no one in your house has COVID, that's great. No one in your house, needs a test, but order your 4 or your 8 if you haven't ordered any from covidtest.gov. But the other thing is that for those with commercial insurance, tests that you purchase just over the counter are reimbursable. And our colleagues over at the Centers for Medicare and Medicaid Services are working really hard with pharmacy partners to make it easier so that people can just show up at the pharmacy, present their insurance, and be able to get, to get over-the-counter tests. So, it's not that we want people to hoard or that we want them to create massive stockpiles, but we do want people to be prepared and to avail themselves of these options. The last thing I'll just mention on the testing front is it's good to just check what's going on in your local community. There are a lot of cities, municipalities, states that have test distribution programs, and just making folks aware of those resources is really valuable.
Yeah, and just to clarify the quarantine guidelines, I looked it up on this. I'm checking with the CDC because I want to make sure I give accurate information. If you are exposed and are not up to date in your vaccination status, then the CDC says you quarantine for at least 5 days, and that you wear a good mask while you're in quarantine, and carefully monitor for symptoms. And one of the things with some of the new variants is the symptoms can be quite mild, like a sore throat or even just a runny nose. So if you have any upper respiratory symptoms, use those rapid tests to get tested. And if you have a molecular PCR test site near you, those are more sensitive, but certainly there is a place now for the rapid tests.
Can someone talk briefly about the the effectiveness of these home tests, especially for the youngest children, because I believe it's kids under 2 can't use them, but correct me if I'm wrong. There's a couple questions about that.
Sure. So the rapid antigen tests, when we deploy them, it's really important to understand their benefits and their limitations. And the first thing I'll say is for any home test, regardless of whether it's COVID or anything else, the test is as good as the sample that you take. So when my daughter had to get tested before she went back to college, I wanted to watch and make sure the swab went up her nose, right? To make sure she was getting a good sample. So that's really, really important. The quality of the sample matters. The antigen tests are not as sensitive as the PCR testing, which means they will miss some people who do have COVID-19, which is why that a symptomatic child should not return to a child care center until they're symptom-free for at least 24 hours, even if they are COVID negative. That's important because, again, we're seeing other viruses like respiratory syncytial virus and the common cold, which we know can spread rapidly when kids get together. So, and they also tend to work best when the child is symptomatic. So that means, you know, there's a role for asymptomatic testing in terms of, you know, if you're going to have a large gathering and you want to just make sure someone isn't carrying the virus, but they're best deployed when you have a symptomatic child and you want to get a result right away. But if that child's parents has COVID and the rapid is negative, I would get a PCR because the probability that the kid has COVID goes way up. If the kid has not been around anybody who's been sick or has COVID and it's negative, then I think you have a higher probability that it's a true negative test.
And the other thing, just to add, sorry, go ahead, Mary.
No, you go, Jonathan, and then
I was just going to say one other thing that I know has come up is, and this is in the adult population, I think primarily, but folks can continue to test positive for lengthy periods of time on PCR as a certain amount of virus continues to circulate in their system. So, I think Dr. Murray's point about the knowing that the sample is a good sample, but also knowing the context in which somebody is taking that test. Did they have COVID previously? Is there somebody in the family who has COVID? Are they symptomatic? They're all sort of inputs into an equation about, whether an antigen test or a PCR test is most appropriate. So I think in the earlier days of the pandemic, we were hearing things like, oh, PCR is good, antigen is less sensitive. And while maybe as a general rule that is accurate, it doesn't mean that a PCR is always a better test to use depending on the circumstance.
Yeah, and hi everyone, I'm Mary, and I'm sorry I joined you all late. It's a real pleasure to be here with you all. I wanted to just add to build on what Jonathan said. I think that that is true, and there is some specific guidance on the CDC isolation and quarantine website about the fact that, as Jonathan just mentioned, you may continue to test positive. I do want to say, even to double down on what Jonathan just said, if you receive a positive test and you have not previously had COVID in the last 90 days, even if it is a rapid test, you should still consider it to be a positive, and you should still take action accordingly. I know we've heard it from the other end as well, where we've heard people say it's less sensitive, and so it doesn't. I can just keep on going on living. As Dr. Murray said, it's a great idea to do a PCR test to confirm that if you would like. And either way, you should still treat a positive test like a positive. On the subject of PCR, I do want to make sure folks know that there is free PCR tests available to childcare providers via Operation Expanded Testing at the CDC, which provided over $600 million for childcare, schools, and other congregate settings to freely and directly request tests. These are swab and send PCR tests. There are age requirements associated with them. I believe they're all eligible for 2 and up, and they require supervision, as Dr. Murray had mentioned as well, for children who are swabbing themselves. But you get a whole rundown from the laboratory who provides them on how to do these. There's interactive videos to do so, but you can go online and request them now. They are freely available. The CDC will send them to you for free. They will pay for return shipping as well, and they get results in between 20 and 36 hours. So they're quite speedy, and highly recommend this resource. Nikki, we can send it to the website to you, but if anyone Googles it, it's CDC Operation Expanded Testing.
I just wanted to note again for everyone, we are going to produce an FAQ document. So we will also provide the few slides I shared earlier, as well as these resources and links that are being shared during this call. So it will all be in one place.
Before you move on, can I just echo what a great opportunity that is and encourage everyone to take advantage of that? With the wastewater data rising for the BA2 variant in certain areas around the country, having something like that in hand with the rapid turnaround time that is being described can really be a very valuable tool in keeping COVID out of the early child care center. And if you keep it out, then if you're not wearing a mask, it's not as big a deal. It's right. So just that's a great opportunity.
I'm gonna now ask a question of Keisha. Keisha, in your experience working with child care resource and referral agencies and child care providers, what do you think the national organizations on this call, Child Care Aware of America, the National Head Start Association, the National Association for Education of Young Children, and the National Association of Family Child Care could do to support the field as they continue to address COVID in their settings? And you're on mute if you're talking.
I'm sorry.
It's okay.
Wait, and now I've been sorry. Technical. Can you repeat? I have the question.
I was just going to say, given your experience working with child care resource and referral agencies and child care providers, what can you recommend for the co-sponsors on this call, Child Care Aware, National Head Start Association, NACI, and National Association of Family Child Care, how we can support the field as they continue to navigate the ever-evolving pandemic?
Right. It's always evolving and always changing. Like, if you blink, the world's changed. And I think as our network, our role in California for our R&Rs, and then the R&R to the child care providers in their communities has really been to translate that, take all of this and get it out to the field in a way that's consumable to the best of our knowledge, but also to keep them up to date and to make clarifications, and to be the one who can go to, in our case, the state, like if it's public health or if it's the Department of Social Services or licensing that has new rules and regulations, and ask for clarification and like bubble it up to those powers that be. So I think what we are the co-sponsors and what our organizations are direct ears to the ground who can have ears to the people who make the decisions and change. So I think it's really imperative that we continue to do that we, like I said at the beginning, that our providers, our workforce was the canary in the coal mine, so that we can pay attention to that canary and not ignore it, and try and get ahead when we see issues arise and uplift them, and also be the strongest advocates we can for the people who are working, taking care of our kids while we are advocating.
Thank you. Let's see, what else do we have for everyone? Okay, people are asking, there have been some thoughts that children are less likely to get COVID from adults, but adults are more likely to catch COVID from children. Is this accurate?
So that's a great question. And we just heard how you blink and things change. And I think this is an example of where this has been the case. So early on, it was very clear with the earlier variants that adults were the primary drivers of disease. I think what we've seen with with the original Omicron is that anybody could give it to anybody. It was just a highly contagious variant. And I think with the new variant, frankly, the data that I've seen are a little bit all over the place in that. And I think some of the reason for that really depends on the population in which the variant is spreading. And the variables that are important there are the percentage of the population that are vaccinated, has a lot to do with how fast it spreads. Frankly, the number of people who recently just had Omicron probably has a lot to do with how fast it spreads, because if you've had Omicron, you may have some antibody protection to the new one. And then the third piece of it is what kind of risk mitigation strategies are no longer in place that will allow things to spread more rapidly. But I certainly think with the new variants, kids are have a larger role in transmission than with some of the earlier variants, where it was really predominantly adult. And I do think household transmission plays a significant role as well. Because that's where you spend time without masks. Yeah, go ahead, of course.
Yeah, and just to add one thing to that, there's a theoretical question of like who passes more to whom, but then there's the practical question of how does it work on the ground, where, as Dr. Murray said, the vaccination rates are really different amongst these different populations. And we see, sort of roughly an inverse relationship between age and vaccination rate. So, folks 65 and older, the vaccination rates are quite high. And as you go down, the 5 to 11 vaccination rate, I want to say, is about 30%, thereabouts. And we obviously have a lot of concern about, once a vaccine is approved for 0 to 5, how high that will go. But we have seen, as each successive tranche, as each age has gotten approved, we've seen a sort of corresponding decline in the vaccination rate. And so I would echo everything Dr. Murray said, and then also just use this as a plug to, continue to push the message of vaccination, particularly for kids, given the relatively high levels of immunity in the adult population.
Just to add one quick thing to that, if I may. The other reason to think about vaccination in children is the post-COVID-19 things that we have seen in a subset. And that's the long COVID, where kids are suffering from fatigue, difficulty concentrating, shortness of breath, or difficulty breathing with exercise. And unfortunately, what we've seen is that who gets that doesn't correlate to how severe their initial COVID infection was. So you could have a very mild COVID infection and have problems weeks out after that. Now, fortunately, those seem like they resolve, but it can take 6 to 9 months. And some families are really struggling with that. So anything we can do, not only to prevent the acute infection, but the longer term consequences, which we're just learning about, I think is critically important.
Okay, I'm going to ask one more question. And I also wanted to officially introduce Mary, since she joined a little late. We're joined by Dr. Mary Wall, who's Senior Education Policy Advisor with the White House, in case anyone was wondering who Mary is. That's who she is, and she's a great partner. And so there's quite a few questions about Operation Expanded Testing. Participants first want to know if their family childcare homes, if they're eligible for this program. And there's also a lot of confusion about there's some reports that when you go to the website, it indicates for school-age children. So, and there's been difficulties for people trying to apply when they're not a school. So if you could speak to that at all, I think it might help people navigate that process.
Sure. Yeah. So I will say yes, definitely, to family childcare being eligible to receive these. The way that this usually works with them is that they are sending them to an individual address. They'll basically ask you how many you want per week, with the assumption that you would do so as somewhat of a screening program. You can also talk to the labs in order to figure out what the right cadence is and how much testing supplies to receive at what clip. But basically, you receive those materials, you train via the materials, some interactive materials that the labs have, and you send them back. As I mentioned, yes to family childcare and other center-based childcare is also eligible. The website, yes, does mention K-12. It also mentions a variety of other settings like historically Black colleges and universities, shelters, settings. There's several that are eligible, but childcare has actually very encouragingly been one of the, as I look at the data on the back end, we've seen more and more childcare sites enroll over the last 3 months in this program, which is very encouraging to see, as well as K-12 schools. We've really tried hard to make sure that this is as easy a process as possible, Nikki, in getting involved. There's basically, if you're on the site, it shows there's 4 different hubs, depending on what part of the country you're in. So it will give a state and the hub that you should reach out to. Those 4 hubs are run by 3 different lab companies. And then those 3 lab companies essentially run the intake process, and then they send things back out. I have walked through all of these with those labs. I do think that it's fairly straightforward, but it certainly does require a couple of steps in order to, there's an initial intake form. They come and they ask you some additional questions about how you're going to do it. And then you have to put your information in for how often you will get these tests. If there are questions, Nikki, there are phone numbers and emails on those sites as well that you can reach out to. I have some helplines for all of those that I can send your way, Nikki, as well. And if there are any questions at all about like, hey, I tried and it can't go through, and you say, Nikki, what would work best. But if we can do the feedback like to me, through me, and I'm happy to engage with CDC on making sure that people know how to do it. And or we can just try to push it out another way. They are eager to make sure that people know how to use it. Thank you so much. And since we're at 4 o'clock, I want to thank everyone. I want to thank our speakers, Dr. Murray, Ms. Nzui, Dr. Warsh, and Dr. Wall, as well as Dr. Fraga for joining us today. As I mentioned, we will have an FAQ document, and it will include links, information, et cetera, and all the different things we talked about today. And we'll follow up. I know some people asked for slides. We'll send you those too. So thanks again, everyone, for joining us. And feel free to reach out if you have additional questions as well. Thank you.